Good morning, everyone. This is Michael Strober, and I have the pleasure of introducing our speaker today, who I've come to know well, Brent Rappaport. Brent is a graduate of the University of Chicago, and of note, after graduating from Chicago, he spent 2 years at the National Institute of Mental Health working with the esteemed Danny Pine, studying the neurocognitive mechanisms of pediatric anxiety. He has an interesting presentation today reflecting his interest in the interface between development, neural systems, and the impact of ecology on how internalizing disorders progress. He has a catchy title, as you see, I Don't Enjoy Relationships, the role of childhood experience in internalizing disorders. And it reflects his master's and dissertation work, which I'll summarize very briefly, on the use of bivariate latent change scores to study the ecology of behavior and the prediction of later psychopathology and the behavioral neuropsychiatric correlates of response to social feedback. I'm sorry? Somebody just yelped. So with no further ado, I give you Brent Rappaport. Take it away, Brent.
Oh, sorry if I was muted. Thanks so much for that introduction, Dr. Strober. Yeah, so as Dr. Strober mentioned, I'm going to be, this is kind of a summary of the research I conducted in graduate school. I'm a clinical psychology intern here at Semel, working on the inpatient service currently. And just to begin, I don't have any conflicts of interest to disclose. And just a reminder to please submit your questions throughout the presentation. You don't have to wait until the end. You can just submit them as they come up, which I know I prefer to do because I can't always remember the questions I have at the very end. So definitely do that. And so my research has really been driven by this desire to understand where questions like this come from. I've really focused on working with adolescents, and particularly adolescents with anxiety and mood disorders. And as I think many of us have experienced, we hear these kinds of statements a lot. Statements like, I don't want friends, or I don't need them. People don't like me. I don't need anyone. Or even kind of this kind of thematic statement of, I don't really enjoy relationships. And so I really wanted to understand in my graduate research, where do statements like this come from? What precedes them, so that we can better treat them. And throughout this presentation, I'm going to argue that they really come from past experiences, kind of chronic past experiences that people have in their life. So the first past experience I'm going to hit on is that of psychopathology. So to begin, this isn't going to be news to many of us, but depression, of course, increases in adolescence. Yet a lot of research shows that young children can experience depressive episodes and even some of the more severe symptoms of depression, like suicidality and non-suicidal self-injury. And we know that experiencing depression early in life is a pretty strong predictor of future depressive episodes and diagnoses. At the same time, there's a wealth of research, neuroimaging research, that shows that depression is related to reward dysfunction. More specifically, kind of anhedonia is related to dysfunction and how the brain, both how people's brains and behaviorally process and respond to rewards. And this shows up not only in relation to current depression or in people currently depressed, but also as a predictor of developing depression in the future, predicting response to therapies like cognitive behavioral therapy, is present in offspring of mothers with depression, for example, so kids who themselves aren't depressed but are at a familial risk for depression, and in those with remitted depression, so those that experienced a depressive episode in the past but currently are not. And so we wanted to build on this research by looking at a cumulative history of depression and how that might be related to reward dysfunction in adolescence. So to do this, and actually the study I use across all of the studies I'm going to be presenting on in this presentation, is I use the preschool depression study. This is a study co-led by Joan Luby and Deanna Barch at Washington University in St. Louis, where I did my graduate research of about 300 youth. It's a sample that was enriched for preschool onset depression. So as you can see, this is a schematic basically of the study. It's a longitudinal study that began with a behavioral assessment arm where youth were recruited when they were in preschool, so about 3 to 6 years old, and then followed up annually. And then partway through the study, they added an imaging arm to the study as well that included structural and task Fmri. And then I'm also going to be talking about some of the event-related potential tasks that we added on later on in the study around this T20 wave. And so critically in the assessment arm, participants were administered a semi-structured clinical interview. So the PAPA when they were less than 8 years old, and then the CAPA when they were greater than 8 years old, or the KSATs more recently. And so the first study I'm going to be talking about looked at this cumulative history of depression. And so we did this by taking the area under the curve of cardinal depressive symptoms endorsed on this semi-structured clinical interview from these assessment waves of data collection, and then looking at how they related to brain responses during adolescence. So these are kids that are followed prospectively since they were in preschool up until they were about 16, and then scanned on a reward task. This is just to give you a sense of like what area under the curve of a depression trajectory looks like. So you can see this is one participant's trajectory just as an example. So there are dips, there are peaks, there are valleys as we would expect, and it's taking the area under that curve. Just conceptually to think about this is pretty highly correlated. That's R equals 0.98 with just taking the average of these points. So that's sometimes an easier way to think about it. And then, as I said, we collected a task Fmri of reward response at this imaging wave. And for that, we used the cards task. This is a task where participants are asked to guess whether a card will be high or low. And then they receive a cue about the likely outcome. And then crucially, what I'm going to be focusing on here is this outcome phase. So then they receive feedback about whether they won money, lost money, or neither won nor lost any money. So these are the group level activation maps. So this is just showing that overall, this is the win, the win outcome contrasted with the loss outcome. And so we see this nice striatal activity as we would expect across participants. And so then from that, we can extract the individual bold signals from each participant and see whether those relate to both current depression and cumulative life history of depression. And when we do that, we see that current depression is related pretty focally with activity, bold signal in the nucleus accumbens. So if you see here, this is kind of the ROI map, and this little red dot is the ROI for the nucleus accumbens. And so we're seeing this relationship such that greater depression, as indicated by a higher score on the Children's Depression Inventory, is related to more blunted response to winning the money relative to losing money, as we would expect and as has been observed in prior studies. Interestingly, This differs from the relationship with cumulative history of depression. So when we look at cumulative depression symptoms since preschool, we see that there's more blunted activity kind of globally across regions within a corticostriatal circuit. So this includes not only the nucleus accumbens, but also the caudate, the putamen, and then cortical regions like the rostral and dorsal, anterior cingulate cortex, and the insula. So really showing more global blunting, whereas current depression seems to be related to more focal blunting. And moreover, when we break this down into kind of developmental periods, so when we break it down into looking at preschool versus school age versus adolescent depression, we see kind of a similar pattern whereby adolescent depression is associated with this more focal blunting in the accumbens, and preschool depression is related to blunting across more of these regions, suggesting it's something about kind of the early onset of this depression that might be leading to greater blunting and perhaps greater risk for depression in the future. So at this point, from this, we drew that past symptoms of depression inform brain responses to reward even over and beyond current symptoms, since in those analyses, we use multiple regression models that accounted for current depression. So this relationship is over and above the relationship with current depression. And so this begins to speak to the importance of taking into account children's experiences with early life psychopathology. The next past experience I'm gonna hit on with two studies is that of peer relationships. So kids' early life experience with their peers. So we know that peer relationships increase in importance and salience in adolescence, and oftentimes this focuses on, this results in a tendency to focus on adolescence when studying peer relationships or young adulthood. However, there's also a wealth of developmental literature that suggests that peer relationships are salient and even pretty complex early in development, and that things like bullying or peer victimization become moderately stable even beginning early in life. So just like depression, it's possible that past difficulties with peer relationships may have lasting impacts on the brain and people's behavior. So the first study in which we sought to examine this a little further was a purely kind of longitudinal behavioral study. So this has no neuroimaging involved in it, just in case people thought I was only doing neuroimaging research. So this was a longitudinal study that again used the preschool depression study. It used 6 waves of data collection. So these earliest waves from when the kids were at the youngest 3 to at the oldest about 13. And we measured peer relationships with parent and teacher report on the MacArthur Health Behavior Questionnaire. And then we measured psychopathology using the clinician administered semi-structured diagnostic interviews. And the original research question for this study specifically, which was my master's, was whether problems in peer relationships lead or lag psychopathology. So this came from some different competing theoretical models in the field. So one was this kind of interpersonal risk model, or this theory that disruptions in peer relationships are a consistent risk factor or indicator of, psychopathology. So you can think of this, if we're using the example of bullying or peer victimization and depression, this would be the hypothesis that kids that are bullied are then at a greater risk for depression. An alternative is a kind of interpersonal scar model, whereby peer relationships are a lagging indicator or consequence of psychopathology. So you can think of this as kids who are depressed may be may show greater social withdrawal and become targets of bullying or victimization. a transactional model whereby kids kind of get caught in a cycle whereby disruptions in peer relationships are both leading and lagging psychopathology. So this, you could think of this as a kid who's bullied or victimized, then goes on to develop depression, which then makes them a target of further bullying and then worsening depression. And then a kind of novel model that we introduced was this developmental model, which you can basically think of as the transactional model, but hypothesizing that the relationship between peer relations and psychopathology may vary as a function of age, may depend on the age of the child. It might be different in early childhood than it is later in childhood, like that. So to test these theories against each other, we use something called a form of structural equation modeling called bivariate latent change score modeling. So I'm going to kind of slowly build up the model because I think it can kind of be overwhelming and kind of confusing if it's just like all thrown together on the screen. So just to begin, the circles are just latent variables, and then the squares are the manifest variables for anyone that's familiar with structural equation modeling. And so this is just to show that, for example, depression at each time point was measured as the percent of depression symptoms endorsed on the clinical interview at each time point. And then that the pure victimization in this case measure at each time point is just the average of the parent and teacher report at each time point. And I should add that the teacher report changed, so it wasn't like the same teacher was being asked long after they've had the kid. It kept up with whatever grade they were in. Additionally, we just included some time invariant covariates as well. So these are just covariates that were regressed onto each one of these time points. Okay, so just for simplicity, I'm going to get rid of the manifest variables. And the first part of the model is this beta parameter. And this basically is just accounting for how much depression at one time predicts change in depression during between time 1 to time 2. So we expect that depression is likely to predict to some extent the change that a kid experiences in their depression between 2 time points. So we want to account for that. And similarly with peer victimization. The next aspect of this model is the slope and intercept parameters or variables. And so these are just meant to account for each individual's trajectory. So we expect, some kids to have a linear increasing trajectory of depression, some decreasing, some stable, and likewise for peer victimization. And so we want to be able to account for that if we're then going to look at kind of these more granular covariations between, for example, depression predicting change in victimization or victimization predicting change in depression. We want to be able to account for just people's general trajectory. So this is basically the essence of a baseline model. In structural equation modeling, you need a baseline model to test the other theoretical models against. And so in this model, there's an assumption that there's no leading or lagging relationship between, in this case, depression or victimization. So those are fixed to 0. In contrast then, to test the interpersonal risk model, we have this assumption that victimization will be a leading indicator of depression. And so here you can see this coupling parameter, this gamma coupling parameter. It's a mouthful, whereby we're assuming that there is a relationship whereby victimization predicts change in depression at each time point. But you'll also notice that this assumption also carries with it that the coupling is fixed across waves. So you can see that by the B subscript. So we don't expect this relationship in this model to vary across time. Similarly, the interpersonal scar model is just kind of a mirror image of that, whereby we're expecting depression to predict change in victimization, but again, remaining fixed across time. And then the transactional model is just basically a combination of those two, where we expect depression to predict change in victimization, and likewise victimization to predict change in depression, but that those parameters are thought to be consistent across time. And then the way the developmental model differs is that now we're allowing this parameter to vary or to be free across these waves, as indicated by these different numbered subscripts. So gamma A1 can be different from gamma A2 and gamma A3 and so on. And same for gamma B1 and so on. So this is basically the transactional model, but these relationships can vary across time. Okay, so what were the results? So in regards to whether peer victimization is a leading or lagging indicator of depression, we found the greatest support for the interpersonal risk model between these two constructs, whereby victimization was a consistent leading indicator of depression, even beginning very early in childhood. So this was really interesting to us. A lot of prior literature had suggested that this might have been the case in adolescence, but there was some rather uncertainty about whether this was the case really early in childhood. And so we were very excited to see that it was a risk factor even in preschool and extending consistently into late childhood. And this is just the full model, and I'm happy to answer any questions. Again, put them in the Q&A if people have them at the end about the model and about other things we tested with this model. So this again reiterates the importance of past experiences, in this case with victimization or with bullying, and how they inform not only immediate but long-lasting risk for depression. The second study really exemplifies also the effect that peer relationships can have on brain and behavior, not only symptoms. And so in this study, again, we use the same preschool depression study. It's a very, very rich data set. So I was able to answer a lot of questions with this, and I'm happy to answer any questions that people have about the sample, those kinds of things. But for this study, we used similarly peer victimization reports from the first 3 time waves, so from this kind of early childhood period and this very recent period, as well as an event-related potentials task called the Island Getaway task at the most recent wave. So this gave us a nice measure of recent peer victimization or experience with bullying and early life peer victimization or experience with bullying in kids in late adolescence that were about 18 years old. So what are ERPs? Just briefly as a primer for people that might not be as familiar, it's a form of EEG. So it provides really high temporal resolution. It's recorded with an EEG scalp that's placed on the scalp. It provides a nice measure of kind of gross brain activity. So the way it contrasts with something like fMRI gives us really fine detailed measures of like where bold signal is in the brain, but it's not as good at on the temporal time scale. So it usually gives you about a second, whereas ERPs and EEGs give you like millisecond time scales, but aren't as good at localizing where the activity is in the brain. It also contrasts with fMRI because it provides a more direct measure of neuronal activity, whereas fMRI is the bold signal, so it's a more indirect measure. It's thought to provide more ecological validity because instead of laying down in a scanner that's making a lot of noise and looking through a head cage on a mirror, participants are seated upright, they just have something on their scalp and they're interacting with the computer. So it feels a lot more natural and thus more comfortable. And compared to something like Fmri, is relatively inexpensive. And so it's exciting to a lot of clinicians as something that would be more easy to adapt and put into doctors' offices as a way to diagnose and assess symptoms. Okay, so just briefly in terms of the Island Getaway task, this is a task that's meant to measure or elicit participants' responses to being accepted by their peers and being rejected by their peers. The way it does that is it sets up this context where participants are playing a game and they're told they're playing it with peers of their same age throughout the country. It's kind of, if anyone's seen the TV show Survivor, it's kind of set up like that, where they're told that they're on an island and they're going to go through rounds of voting where they vote to kick players off of the island or keep them on the island. And they want to make it to the end. And so on each trial here, they see a picture of the other participant and they have a picture taken of themselves and they fill out a profile. So they see one of the other co-players' pictures, sorry, there we go, pictures, and then some information about them, their name, what they're interested in, things like that. Crucially, these are computer generated, so these aren't actual people. So there is some deception inherent in the task. Oops, sorry. They're then asked whether they want to kick that participant out or keep them in the game. And then crucially, they receive feedback about how that person voted for them. So whether they voted to keep them in the game or kick them out of the game. And then that's when we're able to record the EEG activity. And as you see here, this is the grand average EEG activity. So this is the average collapsed across all participants, separated by condition. And this gray area highlights the reward positivity, which is this component in the ERP waveform that is thought to reflect response to gains relative to losses. And here we're seeing a greater deflection or greater brain activity to acceptance relative to rejection in this slightly more central posterior area, which is, this is just the scalp image to give you a sense of where that activity is located. For those that are familiar, we drew this from the CZ electrode. So we can then take individual differences on this RUP component, so the score for each person, and ask whether that's related to their history of victimization. And what we find is that it is such that those that experience more early life, so this green line, victimization or bullying, showed a blunted response to being accepted by same age peers. And that we're seeing kind of a similar direction with recent victimization, but that it didn't reach significance. Interestingly, and perhaps more surprising to me from these results, was that we also found this behavioral relationship such that both recent and early victimization, as you can see here, were related to casting fewer votes to keep other people in the game. So those that had experienced more victimization were also being more rejecting of their peers in the game, which was quite interesting, quite surprising to me. I thought I was a little worried kids were going to play the game optimally and just vote to keep in as many people as they could. But as you see, we're getting some really nice variability in some kids voting to keep a lot of people, some kids voting to keep nearly nobody, and a lot of kids voting to keep a little more than half. So whereas the prior study spoke to how victimization informs symptoms, this is perhaps getting us a little closer to some kind of mechanistic understanding, whereby perhaps victimization informs brain and behavioral responses to acceptance and the tendency to reject others, which then may further inform how they develop depression. And finally, the third past experience I'm going to discuss. I have it here as a mystery because it was actually born out of exploratory results from my dissertation. So it was not what we expected. And so I tell people that just as it was a mystery to me, I'm going to keep it a mystery to you all until we discover it. So at the risk of bearing the lead a little bit. Okay, so as I said, this is my dissertation. So for this study, we again use data from the Island Getaway task. But really we're just looking at cross-sectional data for the confirmatory analyses. This was pre-registered. So this, again, was participants were administered the same task when they were about 18, 19 years old. And the research question for that study specifically was whether brain responses to being accepted and rejected by others really did reflect reward and loss processes in the brain, as is often assumed in the literature, that kind of this construct of social acceptance acts as a kind of social reward that responds similarly to other kinds of reward, eating, winning money, those kinds of things. And furthermore, whether impairments in processing acceptance and rejection might be able to start to explain some of the homogeneity and heterogeneity between depression and social anxiety. It might explain the kind of common comorbidity we see between these disorders. So those were the central questions. I'll discuss those, have what we found, and then move on to the exploratory results, which, as I said, speak a little bit more to the importance of past experiences. So again, we use this Island Getaway task, same setup. So I won't go back over this. I'm happy to answer questions though if people have any about it. I love talking about this task. And so again, we're seeing a very similar pattern in terms of the grand average waveform. This is again collapsed across all participants. And for this study, rather than using an a priori time window like we had in the last study, that shaded region I showed you, we used a temporospatial PCA analysis. This is thought to better extract the ERP components, though there's some debate about that. But here you can see we extracted this reward positivity component once again, though this time at the FC2 electrode. So just frontal and to the right of the CZ electrode. And again, are seeing this greater activity to being accepted than being rejected by others. We also administered to participants this probabilistic incentive learning task or probabilistic reward task developed by Diego Pizzagalli and then further developed by Catherine Luking at WashU, who developed a different version that I'll talk about. So in this task, participants see a blank face. Then they very briefly see either a mouth or a nose flashed on the screen. And then they're asked to make a discrimination. They're asked whether the mouth or nose was short or long. So as you can see, this is a really hard discrimination to make. Some people claim that it's easy. I think it's really hard. And crucially, it's supposed to be hard because one of the responses is more often paired with a reward. So for example, responding that the mouth is long is more often paired with winning money than when you respond that the mouth is short. And what this leads to is a bias towards the rewarded response. So a bias towards responding that the mouth is long rather than it's short. Similarly, in a negative version of this task that Catherine Luking developed, one of the responses is more often punished. So in this case, let's say it's with the nose, responding that the nose is short is more often punished. And so this leads to a bias towards avoiding that response and responding more often that the nose is long. And then we can use an equation like this one to then measure, I'm sorry if that's hard to see, the bias towards a rewarded response and then the bias away from a punished response and then look at how that relates to brain responses to being accepted and rejected to see if those systems really are being involved in the brain's response to being accepted or rejected. So this is briefly kind of a structural equation model of the hypotheses. I'm not going to spend too much time going over these, as you'll see in a second. Again, because the exploratory results, I think, are really the more interesting finding. But you can see here that we did expect the response to acceptance to be related to this behavioral reward bias. This is the feedback negativity, or the brain's response to rejection, to social rejection. And we expected that to be related to loss avoidance. And then we expected to find this nice relationship whereby we hypothesized that depression would be related to a blunted response to acceptance, whereas depression and social anxiety would be related to a heightened response to being rejected by one's peers. So we didn't, in these confirmatory analyses, we didn't find support for those hypotheses that there was this relationship. But we did find a correlation between the brain's response to social acceptance and depression that was actually very much in line in terms of effect size with prior studies. So we found a correlation of about negative 0.09. And this is pretty consistent with 3 prior studies that had found a correlation of around 0.1, negative 0.1, negative 0.11. And so we saw this as a great opportunity to use Bayesian analyses. For those that are maybe less familiar, Bayesian analyses allow you to better capture the probability of your hypotheses given the data, which is a little different than how frequentist analyses calculate probability using the p-value. And because of this, we were able to use this informed prior. So basically what past research suggested the effect size would be and see how that affected our results. It did result in a slightly stronger estimate and one that was much more in line kind of exactly with the prior studies. But then we were able to use a Bayes factor, which is a score that tells you kind of how much support there is for your alternative hypothesis, where higher Bayes factors indicate more support. And we're seeing relatively low support, or the cutoff suggests it's called like anecdotal support. So not very strong, but starting to get some sense that there might be some support for this relationship between current depression and reward. Sorry, I was guessing the reward positivity or the response to acceptance. Okay, now the exploratory findings that I've kind of been hinting at. So in exploratory analyses, we found that lower socioeconomic status in life or of the family that these adolescents come from was related to enhanced avoidance of losses. So those kids with lower income to needs ratio is how we operationalize socioeconomic status. So a lower income relative to the family's needs was related to a greater avoidance of losses behaviorally, and was also related to a greater blunting of brain responses to acceptance. So those adolescents with a family with lower SES showed a greater blunted brain response to being accepted by peers their same age. So I thought this was really interesting because even when I didn't expect, or even when my hypotheses weren't necessarily set up to look at past life experiences, it really was this past experience of economic status that was the strongest predictor, and suggests that SES informs brain responses to acceptance as well as behavioral loss avoidance, both of which we found and has been shown in other studies to be related to depression, that we found that kids with depression tend to avoid losses to a greater degree at the risk sometimes of getting rewards. And appear to enjoy their social relationships less, both really concerning things. Okay, so in terms of conclusions, I hope that you take away from this how past experiences, whether they're in the form of early life psychopathology, experience with peer relationships like bullying, which I feel very strongly about and I'm really interested in, or socioeconomic status, which we know is extremely important in predicting mental health and improving mental health, shape both brain and behavioral outcomes in the form of how our brain responds to monetary rewards or social rewards, and behaviorally, how we learn from losses and how we respond to others in whether we accept or reject them. And I don't think this is like a novel thing to claim, but I think it's just important to reiterate, because it can be tempting to kind of focus on current symptoms or current relationships or people's current situations at the expense of accounting for history, particularly chronic stressors. That many of these studies that I looked at things that didn't just happen once, like whether someone was bullied once, but whether they were kind of chronically bullied throughout life or chronically depressed, or in chronically low socioeconomic status. And I think understanding how these experiences shape patients' current functioning is really key, not only to alleviating their current symptoms, but creating continued remission in their life. So to kind of bring it all back to the beginning, I think I've started to be able to answer this question, but obviously not completely, and it's something I am hoping to continue investigating in my research. And so with that, I've left plenty of time for questions, which is great. And I want to thank my lab and everyone that helped out with this research at Washington University and other places, and particularly my advisor, Deanna Barch, who is a co-author and great mentor in all of this research. So thanks very much.
Thank you, Brent. I have a number of questions, but I'm going to wait till the end. Dr. Senner has a question. I have a similar question, but again, I'll wait. Were you able to find out why kids were victimized? And does the nature of the victimization and what provoked it have any relevance to your findings?
Yeah, I think that's a great question. So we didn't unfortunately know why kids were victimized. We didn't get that kind of like good detailed level information. One thing we did look at is different kinds of problems with peer relationships. So I just presented the findings on peer victimization, but we also looked at kids' tendency to withdraw socially, to behave pro-socially, and to be aggressive towards their peers, as a way to kind of get at that, to make sure that we weren't just capturing victimization that might also be due to them being aggressive towards their peers. And so, yeah, then their peers are going to be aggressive towards them. I think it's a really nuanced question, and it's definitely important why they were victimized, why they were bullied. It definitely would add more complexity, I think, to the relationship with depression. I don't think it would be quite so straightforward if we were able to look at that.
Let me ask you a follow-up question. And to some degree, the question has to do with what you've been experiencing on the adolescent service and what you and I have spoken about in relation to some of your patients. is it not a fact that children who are shy, and that is an anxiety symptom, it's present from very early in development, is linked to the probability of being victimized, of being bullied?
Yeah. So I definitely think it's linked. Another thing I didn't present is we looked at kind of simpler longitudinal models that did suggest that things like trajectory of anxiety was related to trajectory of victimization. So I do agree that the tendency to be shy definitely puts kids at risk for being bullied, but at least in these models we didn't, and that might have been, due to study design limitations, we didn't find that kind of direct support for a direct relationship between things like anxiety and that putting kids at risk for being bullied in the very near term.
But you've seen it commonly. It's very common, at least in the patients who show up on the inpatient service, and that may be a unique population, but it's an association that's not uncommon. Why do you think, there's another question from Rhonda, why would you expect the finding that you reported on SES? And what do you think its larger conceptual mechanistic underpinning is?
Yeah, so I think there's kind of two ways I think about that. So one, from a more like practical standpoint, one thing we've seen in this preschool depression study is that socioeconomic status is this huge driver of risk for psychopathology, and individual differences in things like brain function and structure. So I think one is that it's just such a big cause of those things. The other, the reason why that might be more broadly and how that relates to things like blunted response to being accepted by their peers likely has a lot to do with context, what their experience is like with their peers, and how much those experiences might be valued in a like resource limited environment, in an environment where more kind of fundamental needs like food, water, electricity, kind of all of these things aren't necessarily able to be met. Those likely do supersede kind of the need to have fulfilling and rewarding friendships.
Thank you. Dr. McCracken asks, are there any sex differences in the data that you reported, given that there are certainly sex differences in anxiety sensitivity and risk for depression, especially depressions that develop from adolescence forward?
Yeah, so we get this question a lot. So we didn't find any sex differences. It's included as a covariate in nearly all the analyses I presented, amongst other covariates too. That could be to a lot of things. One is that perhaps we're just underpowered to detect sex differences. It could be something unique about this study, because it was enriched for early life childhood, which doesn't show as large sex differences as early life depression, which doesn't show as large sex differences as something like adolescent depression, where it's much more common in females. That could be one reason we didn't find sex differences.
I have a question that you posed, and that is, are there true advantages of structural equation model or modeling, structural equation modeling, in when compared to the more common approach of using multiple regression in these types of longitudinally focused studies?
Yeah. So I did pose this question because this is a little bit of like a soapbox I think I got from WashU, where, structural equation models give us this really rich opportunity to test how our hypotheses of the world fit the data, kind of all at once. And I think that especially has strengths kind of in this environment where things like computational modeling and AI are becoming more common. Those can kind of yield these black boxes where something we put data in and it predicts something like diagnosis, but we don't know what was going on. And structural equation modeling really gives us an opportunity to very clearly set up our hypotheses and then test those and understand the uncertainty of that prediction.
So now I'm going to ask you a question about uncertainty and complexity in studying mechanistic processes. And again, thank you for the presentation. It's really quite elegant. What do you think your data is missing? And I'm referencing another one of your questions, which is, did you look at other forms of peer-related problems and other types of psychopathology that are relevant to longitudinal studies?
Yeah. So for like the bivariate latent change score model, we did look at other forms of psychopathology like anxiety and externalizing symptoms. And as I mentioned, we did look at other forms of peer relationships problems. But I think kind of a difficulty with kind of a lot of these mechanistic studies is how do you capture the rich environment that these kids live in and develop and grow up in a way that we can also, get down to a quantitative level, and if we'll ever be able to do that. I focused on peer relationships, but undoubtedly there's an effect of the kids' home and family environment, their neighborhood environment, with which one of my colleagues in grad school was really interested in studying, and then the societal environment at large at that particular time. So that's probably what it's missing, is everything else.
I know you didn't find, well, before I get to my question, I see we have another one. Dr. McCracken continues, could you say a little bit more about how the kids were recruited and what the SES distribution of the sample is?
Yeah, and I'll actually re-share this slide because I was hoping to show that a little bit more with this slide. So part of what this shows, so these are scatter plots, but this shows the distribution, in this case for SES, so for the income to needs ratio across at least this subsample. So this is about a subsample of 110 or so participants from that 300 sample. They were recruited from lots of different places, from a lot from mental health practices for preschoolers. As you can see, we tried to recruit not only people high income to needs, but really include quite a substantial number of people that would be below the federal poverty line, but also below what we would consider to kind of be the more practical poverty line as well. One thing my advisor always wants me to mention with this is people a lot of times will ask about mobility and whether we were able to look at SES longitudinally. But to do that, we would need people to have a lot of economic mobility. So we need people who start out at a low SES to move up and people who are high to move low. And whether that's a product of it being a sample from St. Louis, though it seems like a problem more nationally, there's really no economic mobility. People that started the study with low SES ended with low SES, unfortunately.
I want to go back to your point about the absence of any statistical association that emerged in your analysis between anxiety, or at least linked to anxiety. But as you've seen in this population you've spent 6 months with, there is a very significant relationship between early life anxiety, generally captured in generalized anxiety disorder, with surprisingly poor self-esteem and sort of general malaise and neuroticism, even in kids whose families would be described as stable, nurturing, and positive. It's inexplicable because many of these kids have traits that are extraordinary. So how would you understand that relationship between early life anxiety, low self-regard, and positive, supportive, nurturing parental environments? And remember, I already gave you the answer to that question over the last 6 months.
Oh man, now I feel like it's a test. But I mean,
Yeah.
I think it's we know there's some genetic predisposition or some genetic risk for anxiety. And then there can be a number of stressful life events that occur even if the family is stable, that exacerbate that.
What do you make of the fact that in some of these kids, apart from the events that arise immediately before their admission, there are no stressful life events? It's clear that stressful life events will aggravate development, will intensify anxiety, will intensify any depression that's emerging. But in some cases, we can't see. There are no stressful life events that are reported either by patient or parents.
But you said they do have early life anxiety.
Yes.
Well, they have anxiety, it gets worse. I mean, at the sake of being kind of reductionistic, but I mean, I think, yeah.
Yeah, things get worse over time.
Yeah, things that, I mean, I think I've talked with patients too about things, a kind of level of anxiety that might be manageable at one point in a child's life might become more unmanageable, might become more difficult to manage, especially in adolescence where they get more responsibilities, have more volatile parts of their life.
Where do you hope to go now as you prepare to move to Chicago for your postdoc? What's your next step?
I've looked at these kinds of past experiences. That was largely a product of the data set and how best to leverage that data set. And so one thing I'm interested in going forward is further teasing apart the kind of trait risk factors that people have with the things that are more state dependent. So which aspects of brain functioning and behavior represent a more depressed state, depressed mood, or anxious state versus trait risk factors of anxiety and depression.
Well, I see we're 1 minute to the hour. So on behalf of the audience, I want to thank you for a great presentation, a very stimulating presentation. And I congratulate you because more is going to come as you spend time in the Windy City. So thank you very much, Brent.
Thanks, Dr. Strober, and thank you everyone for attending.
I had one more question for you, which is, do you see how positivity, meaning a stable environment, nurturing parents, intellectual ability, creativity, in fact, can become stressful for a child with these attributes who has early life anxiety. How
Yeah.
positivity and adaptiveness in and of itself can sensitize the child with early life anxiety and add to their sense of neuroticism.
In terms of like expectations.
Self-expectations and the inability to grasp what is not graspable.
Mhm.
How can I, with the background that I have and with the attributes that I've been told I have,
Mhm.
lead to such negativity of self experience?
Yeah.
Essentially, the answer is, I don't deserve to be anxious and I don't deserve to be depressed because I have wonderful parents and I have all of these admirable traits that my teachers and my parents say I have been blessed with. So why do I feel as I do?
Yeah. Yeah, absolutely.
All right, well, we'll speak more about it.
Thanks again.
Thanks, Brent.
Bye.